heart disease, and in it, aortic stenosis. So again, what I will be writing right now, that will be very much, um, compressed salient features. So if you go through this, a lot can be covered just by this. If you are not directly from a cardiology background, in that case, I will ask you to go, or request you to go through this number of times, a repetition. If you are from cardiology background, then it's okay. I believe you have more than enough knowledge for passing the cardiology section in the Mrcp part 1. Anyway, so first of all, aortic stenosis. Now, aortic stenosis, very important thing which you need to understand. Mitral valve disease, specifically mitral stenosis, that was mostly due to the rheumatic heart disease. That's the major thing. And be it here, be it somewhere else, even in the developed country. However, in developed countries, mitral stenosis is not much present. However, but even if it is there, then it is rheumatic heart disease is the cause. Mitral regurgitation, yes, it can be in a mixed valve disease. Rheumatic can be one of the causes. Congenital heart disease can one of the causes, and also in most of the cases, it has been seen a functional MR can generate due to some contributory factors, other comorbidities like hypertension or LVH, which is coming from the hypertension, kind of that can happen. Plus ACS. Post that, AMR can happen, mitral regurgitation can happen. So these are the other things, but still rheumatic condition is one of the most common condition towards that. However, coming to aortic stenosis, very important two region. One reason, very common reason for aortic stenosis, specifically in adults, is the degenerative disease. Usually, degenerative disease, that is a degenerative calcification, calcified AS. So one is calcified AS that happens in the elderly. Rheumatic can happen, but always remember, aortic valve is usually the secondary valve in a rheumatic process. So if only AS is present, rheumatic may not be the cause. Yes, it can be MS plus AS may be present, MS plus MR plus AS may be present. Likely mixed valvular disease, there rheumatic pathology may be there. And another very important area where aortic valve pathology can happen, that is in case of congenital deformity of aortic valve, of which bicuspid aortic valve is very common. And in a young patient, if somebody is coming with an aortic valve disease or mixed aortic valve disease, in that case, this bicuspid aortic valve can be one of the very important etiology that you need to remember. This is so much emphasized because in the exam you will be given a scenario, look at the age of the patient. That's very important. And once age is there, so once for you, this is for the young, most common, and this is for the elderly, most common cause. These two always remember. Okay. Now coming to what else, where we can get some aortic stenosis. Yes, it can be in case of hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy, aortic stenosis may be present. It can be in some other syndromic conditions, like suppose one is Williams syndrome. Williams syndrome, where aortic stenosis is present, and here we find a supravalvular aortic stenosis. Supravalvular, so above the valve, the pathology is over there. And in case of HOCM, the disease in the subvalvular. So this is also very important nomenclature that you need to remember. Supravalvular AS is more or less congenital, Williams syndrome. HOCM associated it usually subvalvular because there is asymmetric septal hypertrophy and all those things are changing the LVOT. Remember this for your exam. Once again, HOCM associated with subvalvular. This is the second thing, which is extremely important. Third important thing, what are the clinical features of aortic stenosis? Now, in clinical features of aortic stenosis, you have to be very, very confident to differentiate it from the severe variety of the aortic stenosis. That is very important. Certain symptoms are only present when there is a severe aortic stenosis. And before moving over there, let us discuss. So one is narrow pulse pressure. If we look at the aortic stenosis, narrow pulse pressure, you will be having an ejection systolic murmur. There may be a soft second heart sound, soft second heart sound. These are the clinical features. You occasionally can find S4. There can also be a thrill. Thrill is basically palpable murmur. So thrill in aortic area when the condition is getting more and more severe, and definitely we can also get some LVH features, left ventricular hypertrophy, because the LVOT gradient is becoming high and the left ventricle has to press it very strongly. That's why LVOT gradient is becoming high. This is certain things that you need to remember. Whenever an aortic stenosis patient comes, check for the symptoms, whether the patient is having symptoms. And what are the symptoms? Symptoms can be angina, symptoms can be SOB, symptoms can be syncope. If the symptom, any of the symptoms, if these are present, then it's a severe aortic stenosis, severe AS. Only this you need in the exam and also in day-to-day clinics. And if severe AS is present, the only treatment is aortic valve replacement, or basically the treatment is surgery. So till then you can symptomatically manage the patient. Positive factors you can work on. Calcification, we don't have anything to slow down the progression, but definitely the comorbidities like coronary angio, coronary arterial disease or hypertension or diabetes, we can definitely keep them under control. Occasional palpitation, little bit role of beta blocker is definitely there, but once it is severe, no other treatment will do. The patient should go for the surgery. That is very, very important. If the patient is asymptomatic, if the patient is asymptomatic, but gradient, so that is the aortic valve gradient on echo is more than 50 millimeter of mercury, again the treatment is surgery. These two will save you in part 1 and part 2. Lot of things, complicated questions will come, but look at the thing. If it is a symptomatic AS, surgery. If it is an asymptomatic AS, echo showing more than 50 millimeter of mercury gradient between either side of the aortic valve, then again we need surgery. This is very, very important for your examination. So can we go for valvuloplasty? Usually we go for valvuloplasty. Usually we go for valve replacement. Usually we go for valve replacement. Can we go for valvuloplasty? Basically, valvuloplasty only for the patient who are not fit for valve replacement. So not fit for valve replacement, only then. So maybe the patient is very old, or maybe there is some contraindication to lifelong anticoagulation. Only in such condition, valvuloplasty maybe we can go for that. So not much scope of medicine in a critical AS. So most important decision that we need to make, whether we should refer this to CTVS or not, and that is the aptitude which will be tested in the examination. That will be enough for you. Coming to the moving to next one, that is the almost valvular diseases we have completed, but one area is left, that is the mitral valve prolapse. Mitral valve prolapse. So what is mitral valve prolapse? Basically, usually the cause may not be found, but a number of wide associations are present. So associations of mitral valve prolapse, if we look at, it can be associated with cardiomyopathy, can can be associated. Just give me a second. So it can be associated with cardiomyopathy. It can be associated with Turner's syndrome. Turner's syndrome, very common. Also in cases, you can get a case of this Turner's syndrome, Marfan syndrome, osteogenesis imperfecta, Then congenital heart disorders like PDA, ASD. Again, remember these two can also be connected with Turner syndrome. So these are very important associations of mitral valve prolapse. What will be the telltale sign of a mitral valve prolapse? The patient will be having a late systolic murmur. Late systolic murmur. That's one. And with a mid systolic click. Mid systolic click. So these two, again, very important. Try to find out these two phrases in the question from where you can identify whether it's a mitral valve prolapse. What else? Occasionally, you can find features of AMR, features of long QT syndrome, features of thromboembolism, and occasionally in unfortunate people, sudden cardiac death can be associated with mitral valve prolapse. Treatment, again, fortunately for Mrcp part 1, not much of a treatment will be asked actually. Symptomatic treatment. Also look for the change in the cavity, basically change in the cavity. So we have to go for an echocardiogram, basically, and occasionally we have to look for a look to the heart through a transesophageal echo. If the patient is symptomatic and volume overload or LV systolic functions are low, so basically same approach. Symptomatic patient or LV systolic ejection fraction is low, we can go for a valvular surgery. Again, whether we will go for a valve repair surgery or valve replacement surgery, that depends on a number of features and also on the discretion of the cardiac surgeon. And depending on the features on we find on a transesophageal echo, transthoracic echo. Therefore, these questions you are not going to get for your examination. Always remember, if you find some association with congenital heart disease, or in a female, young female, somebody is coming with a murmur with a systolic murmur in the mitral region and occasionally a mid-systolic plaque, that is MVP. And the major condition, you have to think of certain areas like whether MVP patients, they are prone to develop long QT syndrome or they are prone to develop various arrhythmia. So there you need to guard these patients. You have to send them to further evaluation. That's the part of the of I mean Mrcp part 1. That is sufficient to know. Okay.